Okay, so we have primary medical diagnosis of diverticulitis of the large intestine with abscess without bleeding. So primary assessment is gastrointestinal system. So we're going to look for hypoactive bowel sounds, especially because she had surgery on her sigmoid colon. Um, Assessing for those first signs of flatulence, making sure that everything is kind of starting to come together. Obviously not right away. It's going to be a lot less. There's going to be faint there's going to be faint but audible sounds in there. So next we're going to check for nausea and vomiting, and maybe report that for a PRN for an anti-nausea med, because we'll be able to keep fluids down, and then we will avoid having dehydration. We're also going to assess for tear and sutures, which, I mean, we wouldn't actually technically see inside of the colon, but we can assess that by checking for fever, low blood pressure, having difficulty breathing, fast heart rate, which can lead to sepsis. And so you want to get ahead of, then if you have any of those, then you can get ahead of the sepsis, because you don't want to go into septic shock if that fecal matter is leaking into the patient. Then we want to watch for INOs, and we want to document those to make sure it's equal, make sure everything's working correctly after the patient just had surgery. And then you will see if the patient is tolerating those liquids, or if not, is there a blockage, liquids and food. And then you can assess, like, is there a blockage? Is there not a blockage? Why is the patient not handling those well? Next would be the immune system. We would check for infection of the site by checking labs for white blood count. By checking white blood count, you would monitor 1 day after post-op. The reason being is because they could be elevated on the first day because the patient did have surgery. And then, after, you would assess to see if the white blood count started returning to normal, then everything was good. If it stayed elevated, then there could be a sign of infection, and then you would have to do further assessment from there. Next would be checking for redness, tender, and swelling. Now, I know we did say you're not going to necessarily pull the doctor's bandage off right away, and some doctors don't like that. But I think that if you did have like an inkling that there was something affecting the immune system, you could always check for redness, tender, swelling. You wouldn't want to palpate too much on there, but you can always, look around, see if there's obviously, more of a reddish than kind of a healthy pinky look around there. You can always get subjective information, ask the patient, pain scale 1 to 10, how much it's hurting. And then if that were, then if it were tender, or if it was healthy pink and red, there would be no concern with the swelling. You would check for purulent drainage, so something that's like going to be green, yellowy. So when you're changing that dressing for the first time, or the doctor is, you can always check it to see, okay, is there dryness? Was it serosanguinous? Was it purulent? Because you can document, and if it is looking like there's an infection because of those, and there's those white blood cells that are elevated, then we might need to do something. Check for elevated temp. That's another sign of infection. So you can always compare to their baseline temperature to see if, if they're usually high, is it not really a concern, but if they're usually low and now it's elevated. So this patient had temperature before surgery and will continue to monitor if spikes. So this patient actually did have temperature before surgery. So that's something that would be a little bit harder to assess, but when you check all these other things, it'll come together. Next would be cardiac system, checking for hemorrhage. And you would do that by checking the blood pressure would be down, pulse would be up. There could be blood and stools, unusual bruising around the site or in the abdomen. And then, of course, doing labs like hematocrit to see what the levels are. And if those were positive, then yes, it would be a hemorrhage. And then we would want to contact the surgeon or doctor. Then we want to assess for stroke, because the patient did just have surgery. Also, my patient specifically has hypertension. So you want to check for elevated BP, pain, angina, CT. And then you would do you could do like a CT MRI if that was something that the healthcare provider wanted to do. This maybe should have been over here, but I just added in there that there was a previous assessment of previous blood pressure assessment with pain. So that's something just important to watch with this patient because of her history. And finally, going back here. Sorry, that's what I skipped. So high blood pressure, and then checking the blood pressure, PRN meds as needed to bring that blood pressure down because she has a previous history. And then going back to arrhythmias, checking for arrhythmias because my patient does have a history of congestive heart failure, so it's not pumping quite correctly. So just checking for those arrhythmias after surgery. Auscultating and listening to that blood flow, those S1, S2 sounds to see how is it working, how is it sounding, and then that would be because of that history of congestive heart failure. If there was something, you would report that right away to your healthcare provider. Next would be cardiac system. So checking for I already did that one. Okay, so going to pain. Then you check for abdominal pain. Obviously, the patient's going to have some abdominal pain, but getting ahead of that pain because we want to give a around the clock medication to make sure the patient is, not hurting and that they can rightfully assess all the other vitals and give other subjective data. And like I said, you can always palpate. You don't want to actually touch the incision site, but you can kind of palpate and you can look at it and just kind of see what it's looking like to see if there's an infection or no in there, because you can't really make the pain go away. If there's an infection, then that's going to lead to antibiotics. Chest pain specifically for this client because she has congestive heart failure and chronic ischemic heart disease as a history. So, check for signs and symptoms of angina. Is it, in those key spots where it's hurting? Auscultating and listening for that congestive heart failure. And then making sure she has those making sure she has those IPCs on there. Ambulation as soon as possible, as long as we can get that pain under control to make sure that we're not going to have that angina, chest pain, all that. Checking for peripheral pain, so like DVTs, anything like that. Again, we're going to want to do those ICPs to prevent that. Rotating, even dangling right away just to make sure, even if she isn't fully oriented to walk. And then respiratory pain, shortness of breath, because she has a history of respiratory heart failure and she did just have surgery. And then we'll want to do that incentive spirometer, even just for those first 2 days every hour to get that working for her. Risk factors are because she has a history of hypertension, and it was poorly regulated. They were working on regulating it before surgery, so we'll probably continue to regulate after. History of colon cancer, diabetes, has poor pain management, has a hard time stating when the pain is above what it is, which is why this pain assessment is really important, because patient has had a history of not giving correct pain, or I shouldn't say not giving correct, not necessarily telling the truth about her pain, and then her blood pressure spikes, which is why we need to get this regulated. Patient does have a history of depression, so making sure that they have the right education and everything when they go home, checking for those suture tears. Complications that can occur: hypovolemia, high blood pressure, sepsis, suture tearing, infection. Want to check for all those vitals, especially blood pressure up and down, up for hypertensive crisis and down for hemorrhaging. Pulse going up would be for hemorrhaging. Temperature going up would be for, if they're having that infection. Respiratory down for respiratory failure. Ultrasats down for the same thing. And you want to check all those. She had a lot of irregular labs before. Want to make sure those are all getting back to normal. We want to watch those complications that occur. If we're not watching those regular labs and comparing them to before, then we're not going to be able to get the patient back to 100%. Following the vitals, what they say. So if something is high or low, really watch it. Report it, because she did have a high temperature, but if it's not going down and you just think that's the baseline, that infection is going to take over. Ask patient subjective data and take that, like they said, with the feeling of doom, impending doom, and the patient knows what their pain level is. Following and listening to what the patient says, we can stop those complications if we get ahead of it right away.